everyone, and we'll be starting today's workshop. It's Oncofertility workshop, and the theme is bridging the gap between oncology and fertility team, clinical pearls of wisdom. Now I'm very happy to conduct this workshop now consecutively third time, and we were discussing majority of the theoretical factors like how the cancer and cancer treatment it affects the fertility, and especially this comes into picture in the young cancer survivors and how we can improve the quality of life. But the main aim of today's workshop, what I want to achieve at the end of this, is we want to keep it more and more practical. Where I'll tell you the agenda of the session. I think, can I have the screen, please? Yeah. So the first, I'm going to discuss about the concept of the oncofertility. Nothing much theoretical, just a broad overview. And in that, I want to cover what current challenges we are facing in developing a proper ideal oncofertility setup. And once we understand the challenge, how collectively we can overcome those challenges and how we can formulate such a kind of the unit, and what are the key features of those kind of unit and practical difficulties. And at the end, we need to come to a practical solution, like how we can make it very much feasible, accessible, and affordable to our patients. Then we will just, my colleague Sangeeta, she is an embryologist, she will be discussing fertility preservation strategies in female and male. And then the most focused one would be our panel discussions, where our main focus is how combinedly we can approach such cases. So we will be discussing some case scenarios based on, one is the oncological point of view, then how the counseling will be done at oncological end, then how the patients will reach to our end, how the fertility team will make sure the different options available to them, how we give those patients again back to the oncology, and how they will again complete the circle of the fertility after curing when they come to us for the pregnancy. And we have our eminent panelist. I welcome you all. So Dr. Nikhil Kalyani, he is a consultant radiation oncologist at Jaslok Hospital and Research Centre. And we have Dr. Bhausaheb Bagal, he is professor and consultant medical oncologist at Tata Memorial Centre, Mumbai. And we have Dr. Sampada Desai, she's gynec oncologist at I think Hinduja Hospital now. Yeah. So I welcome all our eminent panelists. Thank you so much for joining us. And without wasting time, I would start with my first talk, just short one, to give an overview about the concept of the oncofertility. Now, as we know that this is the era of increasing cancer survival rate. And as these young cancer survivors enter their reproductive years and contemplate pregnancy, it is very important to understand the impact of the cancer and its treatment on fertility and pregnancy outcome. So a very strong predictor of emotional well-being is feeling healthy enough to be a good parent. So different studies have shown parenthood can represent normalcy, happiness, and life fulfillment in the cancer survivors. So as we know that nowadays there is a great shift of focus from survival only to the survival and quality of life. So here our role comes in to this. Okay, so the importance of fertility preservation is receiving specialized counseling about reproductive loss and fertility preservation is associated with less regret and greater quality of life for cancer survivors. This have been proven in many studies. We have got the examples also. So at the end, I'll be telling you our real life scenario cases, what we have treated at our centers. So how the people were gone through the regret and then ultimately they have completed the family. So this is actually true, and that gives us the very important aspect of the fertility preservation. So there are different international organizations like Oncofertility Consortium, ASCO, then fertility organizations like ESHRE and ASRM. So they have demonstrated international standard of care is to provide clear and consistent information about the impact of cancer treatment on fertility and fertility preservation options where there is a curative intent. So it is very, very important to at least discuss these points to all the patients. And then comes what exactly is the oncofertility. So oncofertility is an umbrella term which includes care from both cancer as well as the fertility healthcare providers. So it's a combined approach, and it involves detailed discussion about the risk of fertility due to cancer and its treatment, like chemotherapy, radiation, as well as the surgeries. Then what are the fertility preservation options available? And then the cancer treatment related complications, other complications like pubertal delay, then menstrual problem, hormonal deficiencies, as well as sexual dysfunctions. So all these discussions include this oncofertility umbrella. And here at the same time, providing detailed information to the patients as well as to their spouses, families, that is there. And at the same time, providing the psychological support. So it is not just one or two persons, or not just fertility and oncology. It includes all, even the psychologist and then the counselors. So it is basically, it's a complete team which deals with all this. So oncofertility was just an idea 15 years ago. And today it is a distinct field of medicine offering new hope to cancer patients who will survive their disease with options for preserving their fertility that prior generations lacked. So basically, what are the key components of the oncofertility care? So most important is what, as I discussed, the information, right information to be provided. So it's the information provision. At the same time, age appropriate communication, because we will be dealing with especially the young patients, young adolescents, sometimes pediatric population. So age appropriate communication is very, very important. And so that's why there is a role of the psychologist, counselors, and even the mental health professional into this. At the same time, as I mentioned, psychological support, and at the same time, the financial support, because it is not just theoretically we are discussing. We need to tell them how practically it is possible and how we can support them while they are going through this cancer treatment, as well as at the simultaneously whether these options to be considered. So what are the challenges in this fertility preservation decision making? And these challenges are important because actually these are the points which we have to consider, and we have to analyze each and every point to give the better units for these patients. So basically we need to give, there are multiple sources of information available. So like from the doctors, from the families, societies, social media. So basically we need to give them a proper information. So any decision making, to make it very clear, we need to give the proper information first. So for that, one is proper information from the doctors. It can be in the form of the visuals, audio visuals. At the same time, a proper information booklets that we prefer, because then there will be detailed information, and it is not easy for them so to understand that information at one go. So obviously we need to give the proper timeline for them. It is, we can't expect them to immediately react on those and immediately give the decision. So it is like they should take little time to understand and then decide upon it. At the same time, it is very, very emotional crisis, because there is a cancer diagnosis. They don't have much time. One is, of course, they have the, there is an existential crisis. They don't know, or uncertainty about the survival and what would be the future. And at that point, they have to think about whether they will, think of the fertility later on. So that is very complex state of mind. That's why we require a psychological support at this time. And at the same time, because we have a very tight time frame to make the decisions, because there is a hurry in giving the cancer treatment. So we don't want to waste time either. So that's why it is very critical time frame. And at the same time, for the patient, it is important to understand the reproductive function. So that means it is more in the young and adolescent age group. So first they need to understand the reproductive biology, then their future desire for the fertility. And at the same time, important things are issues of geographic access to the care. So we should be knowing, especially where the centers are available. Is it nearby? How accessible it is? How feasible it is? And at the same time, how affordable it is. Because financial constraints, it is quite a lot. They have to go undergo too many, multiple cycles of whatever surgeries, chemos, radio. There is a long treatment. We don't know about the whatever prognosis. At the same time, they might have to spend here. So we will come to it, like how feasible it is and costings of it. But yes, these are the challenges where we need to sort it out. And this I'll come to it. So basically, we need to formulate certain units where we require a one critical point of contact, which many of the international organizations have suggested, something called as a patient navigator. So this is sort of the coordinator, that person who will be constantly in touch with the fertility team, clinical care, that is oncology team, and even that has a easy, accessibility for the patient also, and that person to coordinate so that to avoid the any delay. And there should be a reliable, sensitive person and who should respond very rapidly and empathetically. So that is important. So basically, this is in our hand to formulate like how we can combinedly work and different how we can formulate such a kind of probably one center or whatever, one group of the people who are working like this, like a helpline, and we are helping them out, and those people are navigating the patients to the different teams. So somehow we need to do that. So basically, in certain countries like even Canada and all, it is very much actively done. So it is like we have to take an initiative to formulate the guidelines, basically, like how we'll be doing it and how we can regularize it, basically. So there are certain guidelines for the counseling of these families. So that is more of a at oncological end also. At the same time, it is from the fertility end also. But the first set, this is like a at the oncological point of view, when they will be at the time of the diagnosis. So, and when they have to first discuss about the fertility preservation. So basically we have to set, it is a sort of private discussion. We have to set the environment, and we can't assume that they will be knowing already the things. So we need to start from explaining the reproductive biology, then give the time for processing the information. So we have to provide the right information, especially some written material where they can little bit think and then take the decision. At the same time, in the adolescent age group, it is not like just parents can take decision on behalf of the kids. We should take a help of the pediatric counselors, and even children should be actively involved, and age appropriate communication has to be done, and there are different tools available for it. So we need to make use of that. So basically, our aim is to formulate such a kind of the clinical pathway for the oncofertility care. So it is at the first, like oncology team, when there is a first diagnosis and there is a need for these kind of the oncofertility services, then that first documentation has to be done. What is the risk to the fertility, and what kind of counseling is been done, and what options have been given. So this is the documentation at the oncological end. And then this coordinator, it will go to the coordinator who is coordinating, and then immediately they will direct that patient to the fertility team. So here basically right now we don't have these, this is the missing part. We have the oncological team which are working at their end. We have our fertility units which are working at our end. And then sometimes as a doctor's consultant level, we coordinate with each other. But still, it may not be possible in the busy units every time a doctor's coordinating. So we require such a kind of the middle navigator. So it can be like with whatever 24 hours helpline or something we have to formulate, where immediately at the diagnosis, these people will decide, once the consultant from the oncological side has given okay, these patients have received the counseling, and immediately they have to direct to the fertility team, and the necessary things will be done, necessary procedures would be done. And at the same time, we will be, I'll come to that, like what we need to know at the time of the referral. And once the completely that preservation has been done, and again, it is very important for that patient to go back to the oncology for the further treatment without any delay. So that is also very important. So the role of this coordinator will be important, and we need to formulate that. So this I was talking about, like handover from oncology to fertility team. So what exactly we need to know is the brief history. What is the diagnosis? Then developmental maturity of the patient. Then plan treatment. What is the plan of the treatment, and urgency? That is very important. So how much time we have is this, especially for the female patients, because we need to do the ovarian stimulations in them. What is the prognosis? And then obviously the handover of the patient and family's understanding of the diagnosis. Then what are the initial, at the initial consultation, what are the options given for the fertility preservation, and what was opted by the patient, what any other procedures planned, is there a need for the menstrual suppression, and other factors like pertinent to the cancer and reproductive potential, like what is the likelihood of the radiotherapy relapse. Then factors that may specifically increase the surgical risk, like mediastinal mass, if there's a battle scar abdomen, or significant immunosuppression is there, bleeding disorders, and presence of a malignant abdominal or retroperitoneal mass. So that also we need to know. And social concerns of the family, like any custody issue or parental disagreement, in especially cases of the pediatric and the adolescent age group. So basically these are the things which are required at the time. So definitely this is the picture of our center where we have all these facilities. So we require all this. I mean, a high-tech embryological lab, we should be having workstation. Then these are the incubators. Then cryopreservation units. So all that will be covered by Sangeeta in the strategies. But this is like, I mean, it's rightly said that nature nurtures for 9 months, but science struggles for mere 5 days. So it's very meticulously we can do it, and then we can preserve these gametes for years together, so to give them later on the happiness. So, but currently what we are facing, what is coming in between, is these three kind of things. So currently we are having information gap, we are having data gap, and we are having option gap. So very less people are having the information about it, awareness. So we are trying to do it, conducting these workshops again and again, making this awareness. More or less the things are same, but we just have to, repetitively discuss it to have the good emphasis, so that we are giving the right information. At the same time, right data is available, because when we are doing more and more cases, we need to store the data, we need to contribute in the research, so that the similar data can be used, and then we can make a contribution in the research. At the same time, option gap. So these different options, from just what you can say, oocyte preservation, semen preservation, embryo, to the tissue preservations, they are available. So that has to be known by the clinician as well as the patients, and then really we can make a difference. So always, and the last time also I had said, so it's really a time to merge. We should have a specific entity as a Oncofertility combinedly, and there is a need to formulate certain guidelines and work accordingly. And so definitely we can form a good Oncofertility program, where we have to have, there are certain what you can say, goals for this. So it is like we have to, what would be the goals? Like to provide timely and comprehensive fertility risk and preservation consultation. So it is important timely at any time. So it should be like 24/7 available services, offer patients to a range of appropriate treatments. So it should be all ranges of the treatments available, inclusive of the treatments which are experimental, like tissue preservation. So to serve as a resource for patient and healthcare providers who are seeking up-to-date fertility preservation information. And then offer, at the same time, we should be offering genetic counseling for genetic cancer risk assessment in the relevant group of the people, and offer other necessary reproductive health services like contraception, sexual health, menopausal management, because of course it leads to premature ovarian failures and all. So just to summarize, all patients and families have the right to know if their fertility is at risk, even if there is no time to do anything about it. So at least a word to a patient is important. Even if there is no time to do anything, or there is nothing that can be done, or prognosis is poor, we do not think it is a good idea or necessary to preserve a fertility. Still, it has to be discussed as per all the guidelines. And when it is judged to be medically safe by all relevant means, with our information and support, the decision then rests with the patient and family. But we have to document that discussion was made, and then what was the decision at the end of the discussion. And then the written resources to be provided, so that this is very important as far as the fertility preservation, oncofertility guidelines or preservation is considered. So that basically at the end, what I wanted to conclude is we need to formulate these kind of the guidelines and formulate one referral pathway, which is very easy for our patients. So I would call Sangeeta for next thing, because already the time is, I think it's moving fast. So I'll call her for next topic is fertility preservation strategies. And then later on, we'll go to our panel discussion. Thank you.